Now we're going to move on to higher mental functions. We're going to talk about language. We're going to talk about memory, both short-term memory and long-term memory. We're going to look at the electrical current of the brain, and we're going to look at the brain waves that are created by that electrical current. We're going to talk about consciousness, and then we're going to talk about sleep and awake cycles. You may be familiar with REM and NREM. I believe we've already talked about Broca's area and Wernicke's area. I'm just bringing it up again under the language category of higher mental functions. So Broca's area was involved in speech production, so this was a motor area of the cerebral cortex. And then we had Wernicke's, which was involved in understanding the written and spoken words, so this was a sensory area within the cerebral cortex. We have different kinds of memory. So here we have declarative, this is the memory of facts, and then we have procedural, which you would think is doing the same skill over and over again. So think about riding a bike, playing the piano, driving a car. I'm sure we've all driven home and we don't remember making all of the turns, right? Because we're using procedural memory. I want to touch down here at the bottom, they mention emotional memory. So basically memories of experiences that you've linked to an emotion. They give you a negative one here, heart pounding when you hear a rattlesnake. This emotional memory could also be the birth of a child or something positive. Two stages of memory here, and we're talking about declarative memory when I talk about short-term memory and long-term memory. This short-term is a temporary holding of information. Usually people say 7 to 8 digits. Sometimes people think of a phone number. If you're trying to call somebody and somebody gives you a phone number, I know that's not how we do it these days, we just text each other the phone number, but before you would have to remember a phone number long enough to dial the phone number. That would be short-term memory. Long-term memory has limitless capacity, and we'll see how long-term memory is developed in some of the future slides. But this is what we're hoping for. This is the goal, especially in any sort of A&P class. We're trying to get you to take that short-term memory and turn it into long-term memory. So more information about declarative. We know that it's factual. It comes from explicit information. This would be like reading your textbook. So related to our conscious thought, our language ability, and our end goal here is to create long-term memory. Second type of memory is non-declarative memory. This is less conscious. You may be doing it and you don't realize you're doing it. Acquired through experience and repetition, best remembered by doing, hard to unlearn. And most of us think of learning to ride a bike. Once you learn how to ride a bike, you always know how to ride a bike, even if it's been 20 years. So it's very hard to unlearn. So how do we transfer memory from short-term to long-term? So everything starts off as short-term memory, and we're hoping to convert it to long-term memory. Your emotional state plays a role. If you're alert and you're motivated, surprised, or aroused, you have a better chance of transferring short-term memory into long-term memory. This is why I tell students, if you have any sort of emotional issue going on in your life, it's really hard to get through anatomy and physiology. There's so much information that you have to turn from short-term memory into long-term memory. If your emotional state is compromised, it makes it increasingly difficult. Also, rehearsal, so repetition and practice. When students say, well, I read the book, and I say, that's great, but did you go over your notes? Did you ask yourself questions? Did you put your questions on one side of the card and your answers on the other so you couldn't cheat? Did you repeat and practice recalling the information just like you would on a test? And then association, which is what I like to try to do. It's hard for some topics, but try to tie old information and new information together. So if I talk about blood pressure and I talk about the difference between a garden hose and a fire hose, you already know how a fire hose works. You've seen it. A garden hose, you probably have one at your house. And you can tie this new information or associate it with these old memories. I like this figure from the book. We can see how sensory information makes it to be stored as long-term memory. You can see that in the cerebral cortex there's a temporary storage. If that data is selected for transfer, it turns into short-term memory. And then if the data is influenced correctly, it can turn into long-term memory. This automatic memory, sometimes we're going to have sensory information stored directly as long-term. This is that procedural. The riding the bike, the brushing your teeth. I think it's important to look at the molecular basis of memory. So anytime we're trying to take short-term memory and turn it into long-term memory, we could see altered neuronal RNA. So remember, RNA makes proteins. Those proteins are responsible for carrying out various acts within the body. We could also deposit them extracellularly outside of the cell, and they could be deposited at a synapse. Remember, a synapse is where two neurons meet. So if I'm doing kind of little stick figures, I usually show something like this. So remember, this is a synapse. So I could have this neuron synapsing here. I could also have another neuron synapsing very close to that same location. We could also have dendritic spines that change. Remember, if you had your soma, it has all of these dendritic spines hanging off of it. Those dendritic spines could come closer to a presynaptic neuron. Remember, we have little receptors here for neurotransmitters. The number and the size of the presynaptic terminals may increase. So what they're saying is I might have one presynaptic neuron, but I could have another presynaptic neuron over here. I could have another. I could have several presynaptic neurons touching this postsynaptic neuron. I could also have more transmitters released. Transmitters are going to be some sort of chemical component, right? We saw this already. That can be released by the presynaptic nerve. So when we say neurotransmitters, we could say acetylcholine, we could say norepinephrine, we could say epinephrine. Now we need to look at brainwave patterns. So there's something called an electroencephalogram. It records the electrical activity that accompanies brain function. Remember, what are neurons doing in terms of voltage? So for the neuron to depolarize, it goes up to negative 35 millivolts, and it goes back down to its resting membrane potential. So we can look at this change in electrical activity, and we can record it as an EEG. I've skipped a few slides so we can actually get to this slide that shows the waves and gives the definition. So alpha waves, you're awake but relaxed. Usually you think of this as your eyes closed. You're still awake, but you're not receiving any stimulus. Then you have beta waves. You're awake and you're alert. So hopefully if you're watching this video, we're all in beta waves, right? Awake and alert. Theta waves, these are common in children. Why is it different in children? Hopefully we know something about the myelin sheaths and when the myelin sheaths develop, right? So we don't have complete insulation for our saltatory conduction until we're about teenagers. And then we have delta waves, which are deep sleep. So the reason I'm showing these, what you should know is just the basic definition, what alpha, beta, theta, and delta waves are. And then also what would be normal. So beta waves, you're normal and you're awake. So what happens if someone goes in to get an EEG and they sit down and all of a sudden they're seeing delta waves but the person's talking to them? That would tell me that something's wrong with that patient, right? Or if you see theta waves, if this is an adult and you see theta waves, that should tell you that there's some sort of issue, or neurological issue with that person. This last definition is important here. A flat EEG means no electrical activity. This is clinical evidence of death. Basically, the patient is brain dead. We should talk about epileptic seizures. This is basically a storm of electrical discharges by a group of neurons, and it prevents any other messages from coming through. So basically, it's overactive nerves. Victims of epilepsy can lose consciousness, have uncontrollable jerking. It is not associated with intellectual impairment. Associated with seizures is something called an aura. It's a sensory hallucination. We also see this in people with migraines. It's almost like a warning that the seizure is going to happen. There's something called an absence seizure. It used to be called a petit mal. And then we have another tonic-clonic seizure. More commonly, people still use grand mal and petit mal when they talk about seizures. You can see petite, that would be small. Usually happens in children, but mostly it's mild. Maybe the expression goes blank for a few seconds, but they check out and then they come right back in. With the grand mal, the victim loses consciousness, loss of bowel and bladder control, severe biting of the tongue are all things that can occur, and it usually lasts several minutes, and this is the most severe type of seizure. Consciousness involves perception, voluntary initiation and control of movement, and processing, or the higher mental functions. If you lose consciousness, we have this word called syncope. It's a fancy word for fainting. What can cause syncope? You can have inadequate cerebral blood flow. What does that mean? That means blood to the brain. I think it's kind of an ingenious system. If you're not able to get enough blood to your brain, your body makes you pass out, or syncope, you faint, and now the blood can get to your brain without having to go against gravity. Same thing with low blood pressure here. If your blood pressure is low, it's hard to push blood up to the brain against gravity. Ischemia from hemorrhage, so you're losing blood and you have tissue death. And then any sort of sudden or severe emotional stress can cause fainting or syncope. Now, one of my favorite topics, sleep. So sleep is a partial state of unconsciousness from which a person can be aroused. You're going to have decreased cortical activity, but the brainstem activity does not change. Remember this brainstem, this is your medulla oblongata, this is your midbrain, this is your pons, and let me spell that right, pons, and remember these are your basic instinct functions. So we're talking about heart rate, we're talking about blood pressure, we're talking about respiratory rate. So your brainstem doesn't shut down, really just talking about your cerebral cortex. And it's not off, it's just depressed. We're going to talk about non-rapid eye movement and rapid eye movement. And basically that we alternate between these two when we're sleeping. We can see with this figure in the book what the EEG pattern would look like with each of these stages. So here's our awake, so we should be in beta waves. Then we'll have REM and NREM, and you can see that most of your dreaming is going to occur in this rapid eye movement phase. And then we have 4 different phases. Some people might call this deep sleep. Sleep can be defined as alternating cycles of sleep and wakefulness. Sometimes we'll refer to this as our circadian rhythm. This is also controlled by the hypothalamus. The hypothalamus is going to release peptides. Those peptides are going to quiet the RAS. If you remember, the RAS is part of the reticular formation, and so we have to inhibit the RAS to stop stimulus from going to our cerebral cortex. Here we have NREM. This is specifically stages 3 and 4, they believe are restorative stages of sleep. People that are sleep deprived or can become depressed and moody, and sometimes this is why sleep deprivation is used as a form of torture. It can make you mentally unstable. So it tells you that sleep is important. One of the things I love about science is that we have to use words like may still. We don't know everything there is to know about REM. This is what we believe. We believe that rapid eye movement occurs to allow the brain to analyze the day's activities, work through any events or problems, eliminate unneeded synapses, basically purge unnecessary information, and then allow for neuronal synapses to occur. That would be turning that short-term memory into long-term memory. Here's one of my favorite figures in the book. It walks you through a typical progression of someone going through the stages of sleep. You can see we're awake here, and then we start going through REM, which is rapid eye movement. If you remember from the previous slide, we said this is skeletal inhibition. This is basically when your cerebral cortex is going to kind of quiet down, right? Remember, your cerebral cortex, the motor division, handles skeletal muscle movement. This is also during REM, if you've ever had that experience where you're trying to go to sleep and you have that free fall event, that happens when you're going from awake to REM. That's because of this skeletal inhibition. Then we go through stage 1, 2, 3, and 4. So now we're in deep sleep. And then We come all the way back up to REM, a rapid eye movement, and then we go all the way back down and all the way back up. I like to think of this as turning the computer on and off. We know that when we put new software in the computer, we have to close the computer, right? You have to restart in order for the programming to work. So basically, this is what we're doing all night long. We're trying to process information, create new long-term memory, create synapses between neurons. Then we're going to shut the computer down and we're going to reboot the computer. Then we're going to shut the computer down, reboot the computer. And so all of this in REM here, this is the time where we're creating new memories. So why do we tell you you need to sleep for 7 to 8 hours, especially before an exam? Here's how much REM you're doing, hour 1 to 2. And then here's 2 to 3. Now here's 4 to 5. Now here's 5 to 6. And here's 7. If you add all of this time up, it accounts for quite a bit of memory creation. If you only sleep 3 hours, that's all the memory that you're able to convert from short-term to long-term. Now we're going to move on to the protection of the brain, and again you're going to see redundancy means importance. If you have several ways in order to protect a structure, that structure is highly valued. So we should know that our brain is our supercomputer controlling homeostasis and a lot of bodily functions, so we want to protect it. How do we do that? We do that with bones, specifically our cranial skull bones, right? We're going to talk about membranes or meninges. We're going to talk about cerebrospinal fluid. And then we're going to talk about the blood-brain barrier. Since we should already know about our cranial bones and their structures, we're going to talk about meninges first. So what do the meningeal layers or membranes do for us? They're going to cover and protect the central nervous system, so hopefully we're thinking brain and spinal cord. They're going to protect blood vessels. We're going to see that inside these meningeal layers, we have cerebrospinal fluid. And there are 3 layers. There's the dura, which is the most outer, thickest layer. There's the arachnoid mater, and there's something called the subarachnoid space, which is what actually contains cerebrospinal fluid. And then there's the third, which is called the pia mater, and it's a very thin layer and it clings to the brain. It would almost be like saran wrap around the brain structure. In this figure, we have lots to look at. Let's look at the layers first. First, we have the scalp here. Then we have the periosteum. Then we have the bones of the skull, and this is a flat bone, right? This is compact, spongy, compact. The dura mater, which is actually made of 2 different layers. I just want you to follow the pink layer for a second, and you can see as it folds inward, and it kind of forms these divisions. It separates the cerebrum from each other, and it separates the cerebrum from the cerebellum, kind of limits the movement of the brain. So it's not just all rattling around within your skull. Then we can see the arachnoid mater, number 5 here. The arachnoid mater is this whitish structure with these little fibers. Kind of looks like a spider, which is why it's called arachnoid. And then we have our pia mater, and our pia mater is this really thin layer, kind of like cling wrap, that sits on top of all of the gyri and invades into all of the fissures and the sulci. Now we need to talk about cerebrospinal fluid. So the cerebrospinal fluid is between the arachnoid mater and the pia mater. So this area right here is filled with cerebrospinal fluid. Kind of acts to clean the brain, like a shower for the brain. We also have these areas, this is the area between the 2 layers of the dura mater that form something called a sinus. And you can see that part of the arachnoid mater invades into the sinus so that we can get rid of the cerebrospinal fluid that's dirty. So think of it like the drain on the shower that's collecting the dirty water as it washes off of your body. That's what this sinus cavity is for. This is eventually going to drain into your jugular vein. You may have heard of the term meningitis before. The itis part tells you inflammation of the meninges. This can spread in the central nervous system, so it can be in the brain or it can be in the spinal cord. Obviously, if it's in the brain, it's worse, right? It's hard for some drugs to get through the blood-brain barrier that we'll talk about in just a moment. But usually this is diagnosed by doing a lumbar puncture. You might have also heard of it called a spinal tap. Cerebrospinal fluid is basically a liquid cushion around the brain. There's several functions here. One, it gives buoyancy to the central nervous system. So you have this top-heavy cerebrum, and it's sitting on this narrow brainstem. So around the cerebrum, we're going to have this watery fluid, cerebrospinal fluid. It's going to have other functions, but one is that it makes the cerebrum lighter or buoyant. Think of when you're in a swimming pool and you're floating on the top of the water, you don't have as much pressure on your lower limbs. Two, it protects the central nervous system from blows. So remember, we are going to have a skull here. We're going to have a cranial bone. And that's going to help against any sort of trauma or blow. But then by having this watery fluid, you can also absorb some of the force from a blow. And three, it's going to nourish the brain and carry chemical signals. So it's a watery solution. It's similar to blood plasma, but not exactly the same. It's going to have less proteins. It's going to have different ion concentrations from blood plasma. It's going to have decreased calcium, but it's going to have increased sodium and chloride. When reading, you can see that the choroid plexus, or plexuses, plural, and the ependymal cells both contribute to cerebrospinal fluid composition. So remember, or look in your book, there's a picture of a capillary, and it'll have red blood cells. And then on the outer edge of the capillaries, it'll be surrounded by those ependymal cells with their cilia. So it takes the choroid plexus and the ependymal cell in order to create cerebrospinal fluid. Great figure here from your book. Let's talk about the creation of cerebrospinal fluid. We have the choroid plexus here and the choroid plexus in the fourth ventricle. You can see them here in red. Remember, the choroid plexus plus the ependymal cells is going to create the cerebrospinal fluid. So you can see it move through the diencephalon, through this aqueduct, goes through these apertures, which then allows the cerebrospinal fluid to wash the cerebellum. Then you can see some of it crosses over the spinal cord. Some actually goes down into the central canal of the spinal cord. As it comes up and around, it washes the pons, the pituitary, and eventually washes all of the cerebrum. Another point that we made earlier was this meningeal dura mater forming the sinus, and that we said part of the arachnoid mater is going to dump the cerebrospinal fluid into this sinus, and then eventually this sinus is going to be dumped into the jugular vein. You can imagine if there's any obstruction that blocks cerebrospinal fluid from circulating or draining, you're going to result in increased pressure. If you're an adult, the skull has fused, and so this is going to keep the pressure within. It can lead to brain damage. It can compress blood vessels. If it's a newborn, the skull bones are unfused, so the pressure is going to cause head enlargement. So hydrocephalus. Usually you're going to drain the excess cerebrospinal fluid. The last form of protection for the brain that we need to talk about is the blood-brain barrier. It helps maintain a stable chemical environment for the brain. It has tight junctions. This keeps the brain separated from blood-borne substances. So you could say microbes, bacteria, virus. We wouldn't want these to be able to have direct access to our supercomputer, which is our brain, right? So selective barrier allows nutrients. Well, we need to get glucose to the brain if we're going to make ATP in order for our neurons to fire. Fat-soluble substances can pass. Some of these are good, some of these are bad. And the blood-brain barrier is absent in some areas where the brain needs to monitor the chemical composition of the blood. I wanted to make sure we remember the astrocytes. So we said astrocytes are in the central nervous system. These are neuroglial cells, helper cells, and you can see that they form these kind of tight junctions over the capillaries, and they police what comes in and out of the capillaries into the brain. The choroid plexus, this is the area that we have direct contact with our blood. So when your blood comes in, even though we're using the choroid plexus to create cerebrospinal fluid, this is also the access point for the brain to monitor the chemical components of your blood. Here we have two definitions to consider: concussion, which is temporary, and contusion, which is permanent. Also, we can talk about hemorrhage. So what if you have bleeding into the subarachnoid or subdural space? Well, there's no place for the blood to go. It's trapped within all of the cranial bones. The only opening is the foramen magnum, if you remember, in the occipital bone. And what can happen is all of the pressure around the cerebrum can push the brain stem through the foramen magnum, resulting in death. The other thing that can happen is that the cerebrum can swell. So you can have swelling of the brain, specifically in this case it would be of the cerebrum, associated with some sort of traumatic head injury. So this would be maybe inflammation, which causes swelling of the tissue. Moving on to brain injuries and disorders, most of us know the term stroke, maybe mini stroke, but here are the real names: cerebrovascular accidents, or CVAs, and transient ischemic attacks, or TIAs. So cerebrovascular accidents, this is when the circulation is blocked. It's usually due to a blood clot, and the brain tissue actually dies. If you have a transient ischemic attack, you have loss of blood flow, but there's no tissue death, so it didn't last long enough in order to cause neuron death. We do have a treatment, something called tissue plasminogen activator. If you want to do some follow-up reading, you can go to chapter 17. And plasminogen activator activates plasminogen and turns it into plasmin, which is a clot buster. And this is a naturally occurring protein in the human body. It's made by the endothelial cells in your blood vessel lining. Don't worry about it unless you want to go review it at chapter 17. Just know that we can give a patient TPA, or tissue plasminogen activator, to help break up the clot that might be causing one of these stroke events. One type of degenerative brain disorder we need to talk about is Alzheimer's disease. A lot of people want to call it old-timers disease, so please make sure that you say it correctly. This is a progressive degenerative disease that results in dementia. And basically, we're just saying mental deterioration when we say dementia. It can cause memory loss, short attention span. They think it has to do with these key proteins that are going to be misfolded, and that some plaques are develop between the neurons, and they're called beta amyloid plaques. And you can imagine if you had one neuron trying to talk to another neuron and you had this plaque, it would stop neuron to neuron transmission. This can cause brain cells to die. This can cause the brain to shrink. Also remember if you remember the hippocampus. So the hippocampus at the core in your diencephalon is affected. Remember, this was part of the limbic system. And the limbic system had something to do with memory. So that's one of the hallmarks of Alzheimer's disease, is memory loss. This is a nice figure from your book. This is a PET, or PET scan. Here's a normal individual, and here's an Alzheimer's individual. The red and the yellow show brain activity, and you can clearly see in these areas here that we have reduced overall cerebral cortex function in the Alzheimer's patient. Another common type of degenerative brain disorder is Parkinson's disease. We believe that it affects the neurons of the substantia nigra. This is in the midbrain area, and it results in tremors at rest. The cause is unknown. There are some treatment options, including dopamine, and we are starting to spend more money on research in this particular area. The last degenerative brain disorder we'll talk about is Huntington's disease. This is a genetic disorder. It is hereditary. You end up with an accumulation of this protein, huntingtin, in the brain cells. It leads to degeneration of the basal nuclei and also the cerebral cortex. Again, it's going to cause wild jerking, flapping movements, later marked by dementia, usually fatal within 15 years of onset. We get to move on to the spinal cord now. So we finished talking about the brain. Now we're going to move to the spinal cord, and we're going to talk about the gross anatomy and the protection. But we know that it's enclosed in the vertebral column. We know that we have vertebrae wrapped around our spinal cord. begins at the foramen magnum of your occipital bone and ends at L1. Most people don't realize the cord-like structure goes to L1, and then we kind of fan out into bundles of nerves. Function provides communication to and from the brain, and then we also have something called reflex centers, and we'll talk more about those. Here's the figure from your book. So as we move through the cervical area into the thoracic area, and we said here, this is about lumbar 1, we're going to see that it turns from a cord into individual nerves. From this first bullet, you can see that the protection for the spinal cord is very similar to the brain, except for there is no blood-brain barrier. But we have vertebrae, we have the 3 meningeal layers, and we have cerebrospinal fluid in the spinal cord. There's an extra area called an epidural space in the spinal cord, which is a cushion of fat. The cerebrospinal fluid still fills the subarachnoid space, just the same as in the brain. And then we see that the dural and arachnoid membranes extend to the sacrum beyond the end of the cord, and this is the site of the lumbar puncture. On the next slide, we'll see this. This figure, you can see we're looking at a section of vertebrae, L5 and 4. Up here at L1 would be the taper or the point of the spinal cord, and then the spinal cord eventually becomes individual nerve, which are bundles of neurons. You can see here, this is the needle doing the spinal tap or lumbar puncture, and it's in the subarachnoid space. So we still have our dura, we still have our arachnoid motor, and then in the subarachnoid space is where we would find our cerebrospinal fluid. One of the positions in which they do a lumbar puncture, you're laying on your side, you pull your knees up to your chest, you're trying to create as much distance between your vertebrae as possible, and they also tell you to be very still and not to move, because it'd be very easy if you pushed the needle too far in that you could damage some of these spinal nerves. Some terminology for the spinal cord. We have a structure called the conus medullaris, and this is this pointy section. This is where the cord ends, and then we have the actual nerves coming off of the cord. The filum terminal is the green fibrous extension that basically anchors the conus medullaris to the coccyx bone. Last term we need to look at is called the cauda equina. It's a bundle of nerves that extend off of the conus medullaris, and you can see them here. They call it the cauda equina because it says it looks like a horse's tail. We also need to talk about the difference between spinal nerves being part of the peripheral nervous system. So the spinal cord is central nervous system. Once the nerve exits the intervertebral foramen, it's now peripheral nervous system. Your textbook has some great pictures of real anatomy. In the cervical region, we can see the spinal cord, we can see the foramen magnum. Cervical area has special structures called rootlets, and you can see spinal nerves. Then in the thoracic section, you can definitely see the cord shape of the spinal cord, and you can see the dura mater. Here in the lumbar section, you can see the conus medullaris, and then you can see the cauda equina coming off. And if you look closely in the background here, that's the filum terminal. Let's look at a cross section, or we may be familiar with the transverse cut. So we can see the vertebrae. We know that this is a cervical vertebrae because it has the transverse foramen. But if we look at the inside structure here in the vertebral foramen, we can see the epidural space, which has fat. It's kind of a cushion between the vertebrae and the actual spinal cord. We can see the dura mater. We can see the arachnoid mater in white, and then we can see the pia mater around the spinal cord structure. You can also see coming out of the intervertebral foramen is where we're going to have our spinal nerves. So the layers in order from superficial to deep, we have vertebrae, epidural space, dura mater, arachnoid mater, subarachnoid space filled with cerebrospinal fluid. We would then have the pia mater and then the actual spinal cord. I want to just point out that we never want to penetrate the pia mater. The pia mater is so close to the spinal cord that you cannot penetrate the pia mater without damaging the nerves that make up the spinal cord. We have a few structures to look at: the ventral median fissure and the dorsal median sulcus. So we know fissure means deep, and we know sulcus means shallow. Median means middle. Ventral is going to be the front side, and dorsal is going to be the back side. We're also going to see a central canal, and that's going to be filled with cerebrospinal fluid. Before we look at the structures in red, let's do a little orientation with this figure. So dura mater is this membrane. Here's arachnoid mater. Pia mater is going to be touching the spinal cord. Here we have gray matter structure on the inside. So gray matter, and then we have white matter on the outside, and that should tell you gray matter slow and steady, white matter fast, myelinated. Now we have the dorsal median sulcus. So on the dorsal side, the back side, the posterior side, we have a sulcus, that's the shallow. On the ventral side, we have the fissure, which is much deeper. Again, you can use the terms dorsal and ventral or posterior and anterior. I'm just used to using dorsal and ventral, so that's what I usually stick with. When we mention the gray matter of the spinal cord, we break the gray matter into dorsal horns and ventral horns. There's also a lateral horn, but I really want to focus on the dorsal and ventral. Looking at the gray matter here, we can see that there is a point, and that point we call the dorsal horn if it's on the posterior side. And on this side, we have a ventral horn, and then we also have a lateral horn. More terminology. There's something called the gray commissure. There are ventral roots, dorsal root ganglia, and spinal nerves. Let's go to the next figure. We have several items to look at here. First is the gray commissure, this area that connects the two halves, right and left half, of the gray matter of the spinal cord. And in the center here, you can see this is the central canal, which would be filled with cerebrospinal fluid. Next, I want to look at the dorsal root. So the dorsal root is going to be this structure right here. Then we have the ventral root, which is going to be this structure here. Again, how do I know front from back? Look at the difference between the sulcus and the fissure. So this would be a deep groove, and this would be a very shallow groove. So dorsal root, ventral root, and then we have a special structure on the dorsal side called the dorsal root ganglion. It's kind of this bump in the road. And remember that ganglion is a bundle of somas, or cell bodies of a neuron. So you have a bunch of somas of neurons bundled here in this dorsal root ganglion. The last term is spinal nerve. I'm going to go to the other side here. If this is your dorsal root ganglion, and this is your ventral root, and this before the dorsal root ganglion is your dorsal root, and after dorsal root ganglion is your dorsal root, you can see that when these two, dorsal root and ventral root, come together, we now call this structure a spinal nerve. And remember that a spinal nerve is now peripheral nervous system, where these structures are central nervous system. The division line is that intervertebral foramen. We need to discuss how information is transmitted between the peripheral nervous system and the central nervous system. So remember, spinal nerve is part of the peripheral nervous system. The roots and the spinal cord are part of the central nervous system. So sensory information comes in the dorsal side. So you can see it goes from spinal nerve here to dorsal root ganglion to dorsal root, then to dorsal horn, and then it's going to go up to the brain. And your brain's going to decide what it's to do with this sensory information. Your brain can send a message back down to the ventral horn, to the ventral root, which then merges to become the spinal nerve, and we're going to have motor action. One thing to notice, sensory information always travels on the dorsal side, and motor information is always transmitted on the ventral side. It's a little more complicated because we also have white matter interaction between the gray matter, the spinal cord, and the brain. And we have three different directions in which these white matter fibers can run. We have ascending. This is going up to the higher centers of the brain where we have sensory input. So you can think cerebral cortex. And so ascending is going to be sensory information. Then we have descending white matter tracts, which are going to go from the brain to the spinal cord, and these have motor outputs. So you can think of ascending is sensory and descending is motor. We use the same terminology to divide up the white matter columns as we do the gray matter horns. So we have a dorsal white matter, we have lateral white matter, and we have ventral white matter. In this lower figure, we see the ascending tracts. These would be carrying sensory information to the brain, and then we have descending tracts, which would be carrying motor information from the brain. So tracts are talking about axons in the white matter here. So we can see these areas of blue, meaning they're ascending tracts carrying sensory information going to the brain, and then the red are the descending tracts carrying motor information from the brain. So it gets a little bit more complicated. Here we have our spinal nerve. Let's say I'm tickling your foot. So if I'm tickling your foot, that information is going to go from the foot to the spinal nerve. Then it's going to travel to the dorsal root and the dorsal root ganglion, and then eventually to the dorsal horn. And then it's going to go to a very specific area within the white matter, specifically your foot, it would be this one, the gracilis. And then it would go through your spinal cord, through your hypothalamus, to a very specific section of your cerebral cortex that would say, my foot is being stimulated right now. And then your brain would have to decide what to do with that information. So your brain would send a message down through the ventral horn, out through the ventral root, to the spinal nerve, and then eventually cause some sort of motor action to occur. So we need to make sure that we understand the pathway from sensory neuron detecting a stimulus to the spinal cord processing it, and then how the motor neuron would affect the muscle. What would the pathway be? So follow sensory information in and motor information out. So we know that the sensory information comes in through the spinal nerve, then it's going to go to the dorsal root ganglion, to the dorsal root, to the dorsal horn, then it's going to jump over to some white matter, it's going to go up to the brain. When the brain wants to send out a motor message, that could go to an area of white matter, but then eventually it's going to come here to the ventral horn, then the ventral root, merge to the spinal nerve, and you're going to have some sort of action occur. Now I did from one side to the other. If we remember our contralateral term versus ipsilateral, it is possible for the brain to send a message back down to the same side and out the same spinal nerve. So if your one hand was in hot water, you wouldn't want the information to go to the opposite hand, right? We would need the muscles of the same hand to pull it out of the water. Now we get to talk about spinal cord trauma and disorders. So you can have something called paresthesias. This is damage to the dorsal roots. This leads to sensory function loss, and this should make sense. Dorsal roots should automatically tell you that we're sending sensory information to the brain. You can also have paralysis, and this is damage from the ventral roots or the ventral horn. This is where we lose motor function. There are two different types of paralysis. There's flaccid and spastic. Here we have the differences between flaccid and spastic paralysis. Flaccid is severe damage where you have no voluntary or involuntary control over the muscles. They're going to atrophy. With spastic paralysis, there's no voluntary control of the muscles, but you do still have reflex activity or involuntary control of the muscles. They're often going to shorten permanently, but you still have some function. Another spinal cord trauma we need to talk about is a transection. It would be a cross-sectioning, or you can think of a transverse cut of the spinal cord. So wherever that cut is located, Any of the nerves below that cut that feed structures are going to lose total motor and sensory function. So if you have a paraplegic, the transection is somewhere in the thoracic or lumbar area, the head and the neck, maybe even the arms still function. And then in a quadriplegic, the cut or transection is in the cervical region. So basically any structure that's innervated by a nerve below the cut is no longer going to supply nerve function to that area. So you're going to lose total motor and sensory loss. There is something called spinal shock. This is a transient period of functional loss due to some sort of lesion on the spinal cord. As we move through some of these disorders, we should be able to look at these words and it should have a little bit more meaning now. So remember, the ventral horn is part of the gray matter of the spinal cord. And what does the ventral horn do? This is where motor neurons send information out to structures in the body. So due to a poliovirus, you can have poliomyelitis. Basically, it damages the ventral horn motor neurons and it causes paralysis. Well, if you cannot send motor messages out to your respiratory muscles, like your intercostals, your pectoralis major, your diaphragm, that could cause you not to be able to breathe, right? Another type of spinal cord disorder is ALS, sometimes referred to as Lou Gehrig's disease. And again, we have more of a slow, progressive destruction of ventral horn motor neurons. Eventually, people with ALS lose the ability to speak, to swallow, and to breathe. Death is typical within 5 years of onset. Next, we can talk about cerebral palsy. This is a neuromuscular disability. So basically, there's something wrong with the neuromuscular junctions, or the message is getting from the brain to the muscle. We can have various levels of cerebral palsy, right? So, or severities, if you will. So we have paralyzed voluntary muscles. This would be our skeletal muscles, right? It's usually due to some sort of brain damage. You can have speech difficulties. You can have motor impairment, so the ability to walk, move your arms. Some patients have seizures. Some have intellectual impairment. And then others are fine. They may be lacking in motor ability, but they're able to think clearly. Anencephaly, this is without brain. Usually parts of the cerebrum or the brainstem never develop. You can see that the child is in a vegetative state, and the death usually occurs soon after birth. On this slide and the next, I talk about spina bifida. There's two different kinds. If you're missing a few vertebrae, that if it's less serious, there's usually no neurological problems. Let's go to the next slide. The more severe and most common form of spina bifida is called spina bifida cystica. There is a sac-like cyst that protrudes from the spine on the backside, dorsal side. It may contain cerebrospinal fluid. Parts of the spinal cord can project into this cyst along with nerve roots. And the reason I mention this is that most cases are caused by a lack of vitamin B, folic acid. So why are we pushing pregnant women to make sure that they take their prenatal vitamins? Well, we're trying to make sure that we have a decreased incidence of this spina bifida cystica. The first part of this developmental slide here, we're talking about the periods of time in which the central nervous system is developing in the embryo. So remember, we're going from one cell, which was the egg and the sperm came together, and you have to take this one cell, and through a chain of events, it has to differentiate into a fetus. It goes from embryo to fetus and then to newborn. So during this period of time, this is when we have central nervous system developing in the embryo. So why are we overly concerned about maternal exposure? Well, because the maternal blood is supplying the nutrients to the growing fetus through the placenta, so we have to worry about radiation or drug use like alcohol and opiates. We also have to worry about infections like virus or bacterial infections. All of these can harm the developing central nervous system of the embryo or fetus. Smoking, I'm going to point out here, is going to decrease oxygen in the blood, which can lead to neuron death and fetal brain damage. People used to smoke all the time during pregnancy, but now we've learned that it can lead to neuronal death and fetal brain damage. So you have a lot of people trying to quit smoking, especially when they're pregnant, because it's been shown to cause harm to the development of the central nervous system. These last couple bullet points here, we can see that the hypothalamus is one of the last areas of the central nervous system to develop. and that the visual cortex, which is very complex, develops very slowly over the first 11 weeks. And then, of course, what happens as we age, we have some cognitive declines, we have some shrinkage of the brain, and if you do anything excessively, like alcohol use, drugs, maybe sports that require several blows to the head on a daily basis, that can lead to senility or dementia that's unrelated to the aging process. Well, we've made it through chapter 12. I'll see you in the next chapter. Bye.